let's move on to the sympathomimetics. All sympathomimetics stimulate the sympathetic nervous system. So we've got the alpha, the beta, and the dopamine, although they do not all stimulate the same receptors. The key to this section is knowing which drugs stimulate which receptors. Now would be a good time to go back and review the functions of the alpha, the beta, and the delta receptors that we previously covered in our G protein-linked second messenger discussion. Let's do a flash quiz here. Time for a refresher. To what class of G proteins are alpha-1, alpha-2, beta-1, and beta-2 linked? Now, I'll give you a second to think about this, because we have 4 different questions I'm asking. What type of G proteins do alpha-1s use, alpha-2s, beta-1s, and beta-2 receptors? What kind of G proteins do they use? If you need more time, just pause the video. Otherwise, let's move on. So alpha-1s are going to be of the GQ class. Alpha-2s use the GI, and beta-1, beta-2s are both GS. Now, did you remember the mnemonic kiss and kick till you're sick of super kinky sex? Remember, kiss correlates for the alpha-1 through beta-2 receptors, and it's a really quick way to categorize the different receptors on test day. So, kiss is going to be our alpha-1, here's our alpha-2, here's our beta-1, and here's our beta-2. So they're going to line up here, where alpha-1 is going to be our GQ, alpha-2 is our GI, and then both are GS. So let's now move on and talk more in depth about the sympathomimetics. Like the cholinomimetics, there are 2 general classes of sympathomimetics, the direct and indirect. So we're going to start off with the direct here. So how do direct sympathomimetics work? Now these agents are going to exert an effect directly on the sympathetic receptors, just like the alpha-1, alpha-2, beta-1, and beta-2 receptors, for example. However, all of these receptors are not going to be activated at the same time. So this is the key. Not all of these receptors will be activated equally. So let's start off with epinephrine. At high doses, epinephrine is going to stimulate alpha-1, alpha-2, beta-1, and beta-2 receptors. However, it is a relatively selective beta-1 receptor at low doses. So how is epinephrine used? Clinically, it's going to be used to treat anaphylaxis, open-angle glaucoma, asthma, and hypotension. We've also got norepinephrine as a direct sympathomimetic. Norepinephrine primarily stimulates the alpha-1 and alpha-2, and it also stimulates some beta-1 to a lesser extent. However, notice how it does not stimulate the beta-2 receptor. It can be used to treat hypotension, but it can significantly decrease renal perfusion, especially when given in conjunction with NSAIDs. This is because there is increased renin release, which is stimulated by beta-1, and vasoconstriction, which is induced by alpha-1, without any vasodilatory effect of the beta-2, since it does not stimulate beta-2 receptors. Isoproterenol, on the other hand, is an isolated beta agonist. It stimulates both beta-1 and beta-2 receptors equally. It can be therefore used to treat torsades de pointe and bradyarrhythmias, but it is rarely used clinically because it can worsen ischemia. What receptors does dopamine work on? Dopamine primarily stimulates D1 and D2 receptors at low doses, beta receptors at medium doses, and alpha receptors at high doses, making it both an inotropic and chronotropic agent. So it can be used to treat shock and heart failure. It's especially useful in the treatment of shock because it raises blood pressure without reducing renal vascular flow. Recall that D1 receptors are going to relax your renal vasculature and smooth muscle. Dobutamine primarily stimulates beta-1 receptors and is therefore inotropic. Let's tie in some cardiology here. Do you know how the equation for cardiac output is? So, cardiac output is equal to heart rate times stroke volume. Dobutamine primarily affects the stroke volume portion of this, making the heart pump out more blood. So if a patient has a low cardiac output due to bad contractility, consider treating them with dobutamine because it increases the stroke volume. Phenylephrine primarily stimulates alpha-1 receptors, and it has a lesser effect on alpha-2 receptors. It can be useful to dilate pupils without producing cycloplegia because there is no sympathetic innervation for accommodation. Its vasoconstricting effects also make it a useful drug for treating nasal congestion. Now, albuterol, salmeterol, terbutaline, and ridodrine are agonists that are more selective for beta-2 than beta-1. So remember that beta-2 bronchodilates, making the airway more open. Albuterol and salmeterol are useful in the treatment of asthma. So what is the difference between the albuterol and salmeterol? Albuterol has a short half-life and is useful for acute attacks. Salmeterol is used for long-term treatment. Now, ridodrine, terbutaline are typically used to prevent premature uterine contractions during pregnancy. So you may see these more at your OBGYN rotation. All of these drugs act by relaxing either the uterine or bronchial smooth muscles. So side effects of these meds can include hypotension at high doses, and since that's the vasodilatory effect of beta-2 receptors, and also muscle tremors. The direct symptomometics are important and may show up on test day. So it would be beneficial just to sit down and learn these receptors and how these common drugs work. Let's do a quick question to show you how you may see these on test day. In a patient who is profoundly hypotensive, so a blood pressure of 80/40, for example, with a minimal urine output, which vasopressive agent could potentially treat both the blood pressure and the oliguria? So we have a couple issues coming into play. We have a low blood pressure and a decreased renal blood flow. So what agent should we use? Personally, I think we should use dopamine. Now this is because it increases blood pressure while maintaining renal perfusion. Now, norepinephrine would also increase blood pressure, but it's going to decrease renal perfusion because it does not affect the dopamine receptors, so norepinephrine should not be used. So my next question is, what receptors does dopamine work on? Dopamine is going to work on D1 receptors primarily, but it's also going to affect beta receptors and alpha receptors. So alpha, beta, and dopamine receptors, depending on which dosage of dopamine you give. So dopamine 1 receptors at low doses, beta receptors at medium doses, and then finally at highest doses, you're going to affect the alpha receptors. So dopamine would be the correct answer here. One way the USMLE likes to test these drugs is with a blood pressure and heart rate graph. So here we've got two different graphs, one that's looking at the blood pressure, one that's taking a look at heart rate. Within our blood pressure graph, we've got two different lines. The top line will represent our systolic blood pressure, the bottom one our diastolic blood pressure. So here's our baseline reading. Now let's give some norepinephrine. Norepinephrine has alpha-1 and alpha-2 effects that are greater than beta-1 effects. So remember, alpha is going to be greater than beta here. So we're going to see some blood pressure change. Now, the alpha-1 receptor is going to raise the diastolic blood pressure by increasing peripheral vascular resistance. Beta-1 receptor has inotropic and chronotropic effects, which should raise the systolic blood pressure and heart rate respectively. So let's build in our heart rate. Oh, that didn't sound right. I just said beta-1 should raise the heart rate. However, the increased blood pressure triggers the body to compensate by decreasing the heart rate in a phenomenon known as the reflex bradycardia. So even though I said triggering beta-1 receptors increases heart rate, here we see some reflex bradycardia. So why did the heart rate just drop? Even though the direct effect of beta-1 stimulation increases the heart rate, the bradycardic reflex overcomes this and produces an overall slower heart rate. And this is because body triggers to compensate from this increased blood pressure by decreasing the heart rate. Alright, so we just took a look at norepinephrine. Now let's take a peek at isoproterenol. Isoproterenol is an isolated beta agonist meaning it affects beta 1 and beta 2 receptors. So let's give some isoproterenol. Let's clear off our board. We give some isoproterenol. Here's the effects that we're going to see. The beta 2 effect lowers the blood pressure with a decrease in diastolic greater than a decrease in the systolic. So we see a diastolic decrease more so than the systolic. This is because if you remember from our discussion about beta 2 from earlier, beta 2 receptor stimulation causes vasodilation. Now the beta 1 effect is going to be the increase the heart rate. So here we see the beta 1 effect increases our heart rate, but it's also going to affect our systolic blood pressure. It temporarily increases systolic blood pressure. As you can see here, normally its overall effect in the long run is to decrease the systolic, but we see an initial increase. This is because the beta 1 increases the heart rate and temporarily increases systolic blood pressure, but after a while the increased heart rate is going to decrease our ejection volume, and therefore the steady state systolic blood pressure will be slightly lower than our baseline reading here. The increase in heart rate is significant because in addition to the beta 1 effect, which causes the increased heart rate, there is also an element of reflex tachycardia due to the overall decrease in blood pressure here. So we may have beta 1 stimulation, we may also see some reflex tachy. Now, you should be able to look at charts like this and interpret these results. To do this, you'll need to take a look at the alpha and the beta effects and how they're going to affect the heart and the vessels.